Chapter 57, HIV Resistance and Genetics. And this is specific training for the HIV resistance sensor. Now, this sensor has two different roles. For one, what is very interesting, some people are resistant to the common types of HIV, the AIDS virus. And this in itself might be interesting, but is not particularly useful. The other part of this test is improved treatment for HIV-infected persons. So let me just show you the concept. You will find this test here, and it really is only useful for treatment. So it might be interesting for some people that want to know, am I resistant or not? But then again, it doesn't have any practical use, and it is more important for people that already suffer from HIV and want to improve their treatment. Now let's have a look at a white blood cell. There are two genes, two copies of one type of gene, of the CCR5 gene, and these produce a receptor. And a receptor is a kind of structure that is on the surface of the cells. So it's presented at the surface of these white blood cells. Now the HIV virus has developed a mode of hijacking this receptor, binding to it, and then using it to get into the cell and then infect the cell with HIV. And the cell would then produce more HIV viruses, release them, and they would then infect other cells. So really the CCR5 gene, which our body produces, is the mode of entry that the virus has hijacked. And if you have normal CCR5 genes, you will be susceptible to HIV. But there are genetic variations that modify the blueprint, the building instructions in these genes. And if a person had two of these genetic variations, they would build a receptor. However, it would be built incorrectly. So it wouldn't work as it's supposed to. It would be different. And what is interesting is that HIV cannot bind to this receptor, cannot use it to get into the cells. So what happens is this cell or this person is HIV resistant. They can have exposure to the virus, but they are not infected by the virus. So you can have two normal genes, then you have a normal risk of HIV, and you can have two resistant genes, and then you're resistant to HIV. And please, this is very important if you counsel a person. This does not mean you don't need to practice safe sex, because there are many other diseases, and these are just equally as deadly, hepatitis and so on. So it's not meant to be interpreted as, great, I don't have to be careful. What this test is useful for is if a person has one genetic variation and one normal gene. They will build the defective receptor, which the virus cannot bind to, but they will also produce the normal receptor, but less of it, and the virus will be able to enter the cells. However, the risk of infection is lower and the progression of the disease is slower. So this really is a more important question for a person that has already contracted HIV. Do I have the normal speed of progression, or maybe do I have a slowed rate of infection? And this is what you can have. You can have the normal risk, you can have the HIV resistance, or a lower risk and slower progression. And that's the three different outcomes. And there's a very interesting story concerning HIV, and I want to explain that. That's a real story. There is Tim. He is German, and he has white blood cells like every one of us, and he was infected with HIV. So the white blood cells were infected, and they were producing more HIV viruses and releasing them, and they were then infecting more cells. So what we know from what I've told you is that he produces the CCR5 receptor because he has normal CCR5 genes. So, as if that was not enough, he was also unlucky enough to produce leukemia or develop leukemia. Leukemia is a cancer of white blood cells. So white blood cells begin to continuously reproduce and divide uncontrollably. And this in itself is cancer and a deadly disease, just like HIV. And for leukemia, the solution is chemotherapy. Now, chemotherapy does the following. It kills off all of the cells that grow rapidly. And this kills off the whole immune system, the whole bone marrow, which produces the blood cells, and all of the white blood cells. So all of them died. All white blood cells were destroyed. And what people do after chemotherapy is they look for a donor that has a matching tissue type, so that the immune system doesn't recognize it as being foreign. So there are these donor banks of bone marrow donors. And the doctors did something very smart. They knew about his HIV infection, and they also knew about the effect of this genetic variation. So what happened is they first killed off the immune system and all of the bone marrow cells that would produce new white blood cells. Then they gave him a bone marrow transplant of a person that had the right genetics, so they were HIV resistant. And this bone marrow then multiplied, it recolonized the bones and produced new white blood cells that were resistant to HIV. And this then caused the person to be cured, not only from chemotherapy, but also from HIV. So this was a very interesting way, a very smart way of using genetics and knowledge about genetics to perform almost a miracle. Now the question is, why don't we do that with every HIV patient? Because around 10% of chemotherapy patients die because of it. So actually doing the chemotherapy is more dangerous than living with HIV with proper treatment. So it's not the cure for everyone yet. It might be in the future, something like this. But this is how this one person was cured. Now if we look at the treatment for HIV, it has gone a long way. If we compare a healthy person, they have a mean lifespan of around 80 years. If you take a HIV infected person that contracts the virus at age 20, what you would see is 10 years of latency. So no symptoms arise. He might have some cold symptoms, feeling like he contracted a cold at the beginning, but then it's usually 10 years of no symptoms. And this is also when he can infect other people. And then the first symptoms arrive, then the acquired immune deficiency happens, AIDS develops, the immune system breaks down, and then bacteria can infect the body, and all sorts of viruses are unchecked and so on. And this then leads to premature death at the mean age of 33 years. So infected at the age of 20, you have another 13 years to live if you don't have treatment. Now treatment, as I said, is very effective if it's done correctly. So you live for 20 years, you get the infection, and with correct treatment, antivirals and antibiotics, if ever there is an infection, you can live around 52 more years in latency, and you might still develop it in the end and have a slightly shorter lifespan, but it's almost as long as a healthy person. So treatment really is very, very important for HIV infected people because it can give them an almost normal lifespan. Now, of course, treatment needs to be effective. So effective treatment, compliance with the treatment is very crucial. And there's the concept of pharmacogenetics. If you don't know what that word means, please do watch the pharmacogenetics training. There's training about how drugs work and how they are metabolized by the body. But I'll quickly explain it again in this example. Different drugs are metabolized, are converted by different enzymes and then removed from the body. And there might be a drug like drug B that goes through a certain gene. However, this gene in this case is mutated, so the drug is not broken down. However, this person might take this drug once every day, And every time he or she takes the drug, the level increases again, until it reaches a toxic level. So these genetic variations can influence which drugs might be broken down slower, which means that they need to be taken at lower dosages. They might also activate some drugs and not activate some others, so-called prodrugs. So some people might just not get a benefit from a drug, and other people just need a different dosage, more or less. And this is what we do here. So drugs for infections, antibiotics, antivirals, and so on. You get this list, just like this in the report, and it tells you the effect is normal, so most of these drugs would work normal. Breakdown is normal. Okay, this is a bad example. All of these drugs are broken down at the normal speed, so it's about 100%, and the dose they should have is about 100%. But it could also be that it says 0% and the recommended daily dose is also 0%, and an alternative is recommended. So then you should really use a different drug if the drug is not cleared from the body at all. Or it might be cleared at 50% of the speed, then you need 50% of the dose. That way you make sure that you get the right levels in the blood, you get the perfect treatment, and you avoid drugs that would cause side effects or not work at all. And this improves the treatment success in HIV, and as I've shown, this is a very critical part. All right, and the prevention or the counseling part, again, this is a sheet of paper in the report which explains it in very simple language, so do read through it. What you need to make sure when you counsel a person is don't tell them this is carte blanche for unprotected sex. There are many other diseases that might be infecting a person with unprotected sex. So if the person is HIV resistant, this does not mean that they can be uncareful. If you're heterozygote, meaning one of the genes has the variation, the other one does not, it's a lower risk and slower progression of the disease. So also it's no carte blanche for unprotected sex. It's just less likely to happen, and it's going to be slower. And if you're normal, you have the normal risk of being infected with HIV. And then the treatment, that's the more important part, is find out which drugs are broken down in which speed, choose the right drugs and choose the right dosages to make sure that the person gets the right benefit from the HIV drugs and gets the best possible treatment. And that's the end of chapter 57, HIV resistance and genetics, a specific training for the HIV resistance sensor.